Welcome all. I would like to thank all the attendee and people, our friends in the individual, to facilitate this grand round at Kekish. Today I will talk about the glaucoma and its risk factors from multiple point of view and multiple combined study, and how we improve our clinical judgment to address those risk factors. I will talk about the primary angle closure glaucoma, risk factors, primary open angle glaucoma, ocular hypertension, and then how we calculate the risk and what is the risk factor. A few slides about the risk factor of progression for glaucoma. As we know, all classification glaucoma based on the multiple factors. We have either you classified by presentation, ocular association, angle configuration, or even the cause of the disease. Glaucoma in general is described as progressive optic neuropathy that is recognized by appearance of the characteristic cupping of the optic nerve, and this is associated with the corresponding visual field defect. And the condition has its basis as a result of gradual loss of retinal ganglion cell and their axon, and as a major risk factor, intraocular pressure. The primary angle closure glaucoma usually a result of combination of predisposing anterior segment anatomy and other exaggerated surgical response, and sometimes triggered by other exogenous factors. The damage in the primary open angle glaucoma to the optic nerve usually as a direct consequence of a high IOP caused by physical obstruction of the aqueous outflow, and this will lead to sometimes degeneration in the trabecal meshwork, leading to iridotrabecular contact. In fact, the iridotrabecular contact is the primary event, usually occurs as a result of anatomical disproportion of the anterior chamber, where the secondary angle closure, most often you will find a cause or as a consequence of either uveitis, iris neovascularization, or sometimes heterogenic factors. We have, in fact, three general outline or factors for primary angle closure. We can divide it to demographic factors, anatomical factors, and we have the precipitating factors. If you can see here, the demographic factors, we have age, more than 60, female gender, Chinese origin, and family history, especially if you have first degree relatives. The anatomical factors, one of the most important and major risk factor was found in primary angle closure glaucoma is shallow anterior chamber depth, especially in the periphery. The other factors also thick or anteriorly positioned or increased anterior curvature of the lens, short axial length, small diameter or increased curvature of the cornea, and at the end, the plateau iris configuration. In fact, as I said, the shallow anterior chamber is the major risk factor for developing angle closure. And if you can see here, the demographic risk factor, which is the increased age, female gender, or Chinese origin, all are associated with a shallow anterior chamber at the end. There is one study done by Louis that he found women have a shallower anterior chamber than men by around 0.160 millimeter, and that was highly significant in that study. As I mentioned earlier, the shallow anterior chamber depth is probably a strong indicator, especially the peripheral depth, not the axial one. Also, Louis, he found or confirmed that people suffering angle closure had shorter axial length in the same study than did the unaffected people. The other factor, we have the precipitating factor. Dim light illumination or dim illumination can precipitate patient to primary angle closure, as the pupil and this setting will dilate and will cause crowding of the angle. Some drugs or medication like anticholinergic, including all the psychologic agents, some systemic antihistamine, antipsychotic agents, can also precipitate emotional stress or severe pain. Can lead also can be as a precipitating factor, as this will cause mydriasis secondary to increase sympathetic tone. So this is a few well known and studied risk factor for primary angular closure glaucoma. On other hand, we'll talk about the primary open angle glaucoma and its risk factor. As we said, usually the term primary open angle glaucoma is applied to eyes with chronic glaucoma, primary, there is no cause, open anterior chamber, and they have to have also elevated intraocular pressure. The other two entities that closely considered with primary open angle glaucoma, people with ocular hypertension, that they have open angle, elevated IUP, but they have no structural or functional damage happen to them. And usually those patients, they are at risk of developing glaucoma. The other entity is the normal tension glaucoma. Usually they have primary chronic glaucoma and open anterior chamber, but the IUP usually within normal statistical limits. Actually, the ocular hypertension is more prevalent than primary open angle glaucoma. This one was mentioned in the Pharma et al. Study that while at least 30 of people in the primary chronic glaucoma in Western country, they have normal tension glaucoma. So, and most of the literature, usually they often they describe risk factor for glaucoma without specifying whether it is a risk for developing the disease or a risk for a progression. As we know, some risk factor can be identified by patient history, like age, race, while you're taking the history from a patient, while the other need to be detected by clinical examination, testing, like intraocular pressure, optic disc examination, functional tests like visual field, and so on. From the study done by Khoury, they review all the risk factors that have been mentioned in the literature, and they found the first four risk factors had strong evidence of association with development of primary open angle glaucoma and also it is a progression. So they found optic disc ulceration, elevated IOP, older age, and African origin to be a strong predictor of developing and progression. And compared family history was a little bit moderate risk factor, while diabetes and hypertension was having a modest evidence. We'll talk about everyone alone. If you allow me, we'll start with the optic nerve. The optic nerve head appearance is perhaps the most significant risk factor and diagnostic sign that, as it is ulceration, basically defines the glaucoma in most of the patients. With current limitation in imaging technology and of the optic nerve head, as well as the biological variability, it remains challenging to isolate well-defined optic nerve head parameter as a risk factor. However, there exists strong evidence that increased cup-to-disc ratio in itself represents a risk factor for progression of glaucoma. Whether an increased cup-disc ratio represents a risk factor or undetected existing glaucoma damage has been debated. This is one of the important points. Sometimes limitation in early detection of structural damage make it difficult to completely resolve this issue. One very important point that is optic disc hemorrhage were associated with faster rate of glaucoma progression in a collaborative normal tension glaucoma study, and also was found to have six-fold increase in risk of developing or establishing primary open angle glaucoma in ocular hypertension treatment study participants. What about the intraocular pressure? As we said, it is one of the strongest risk factors for glaucoma progression. At high enough level also can be a causative factor. Still, it is not clear which dimension of IOP contribute the greatest risk, but higher IOP level are associated with glaucoma progression in PharmaItal study, and variability in diurnal IOP and larger IOP difference between filled eye were found to be more common in patients with primary open-angle glaucoma, 36% versus 6% in normal subjects. So the diurnal IOP range and the IOP range over multiple days were found to be significant risk factor for progression, even after adjusting for the other risk factors like age, race, and visual field damage. One analysis done in the early manifest glaucoma trial with median follow-up of 8 years, the result confirmed that the earlier finding that elevated IOP is a strong factor for glaucoma progression, with hazard ratio increased by 11% for every 1 millimeter per mercury of higher IOP. Also, another study done by Fitchner examining the IOP dependent variable associated with visual field progression, unified analysis found association with mean follow-up IOP, fluctuation, and peak IOP. But when they analyzed these factors in multivariate analysis, they found only the peak IOP to be associated with progression. Okay, so what about age? There is strong evidence that the prevalence and incidence of primary open-angle glaucoma is increased with age of population being studied. This was also confirmed in other population-based studies like Visual Impairment Project and the Barbados Family Study. Another study also done in Los Angeles Latino Eye Study, older age, they found that older age predicted development of primary open-angle glaucoma 2.19 versus 1.74. Also, they found in this study that when you exclude the IOP, the strongest independent risk factor for developing primary open-angle glaucoma was age, with subjects aged over 60 years. They have 7 times more likely to develop glaucoma than those aged less than 40. I guess since glaucoma is a progressive disease, it makes sense that older age is a risk for greater severity. What about race? If we can see here, primary open-angle glaucoma was found to be 4 to 6 times more frequent among individuals of African American origin compared with Caucasian. On average, primary open-angle glaucoma also began at earlier age in African American than Caucasian. Other studies also have been reported notably higher prevalence of glaucoma in individuals of Black race when compared with other racial groups. In the Los Angeles Latino study, the 4-year incidence of primary open-angle glaucoma in Latinos was higher than in non-Hispanic whites, but it is lower than in Afro-Caribbeans, 2.3 in Latino and 1.8 in non-Hispanic whites and 2.8 in Afro-Caribbean. Family history for glaucoma. Also, the exact inheritance pattern is still unknown. As we know, primary open-angle glaucoma is a multifactorial polygenetic disease. In the glaucoma inheritance study in Tasmania, they compared the distribution of patients with a genetically compared familial primary open-angle glaucoma and those with a sporadic type. And they found the familial group was significantly younger at diagnosis and had more severe disease than sporadic group. Also, this finding is in support of value of screening, particularly of family members of individuals with positive family history. The issue is sometimes self-reporting can be unreliable. but in Rotterdam's study, family history was ascertained by direct examination of relatives and not by only patient self-report, and this is very important. Smith, he found in his study that the lifetime absolute risk of glaucoma at age 80 was found to be almost 10 times higher for individuals having relatives with the glaucoma than for patients with negative family history, 22% versus 2.4 respectively. Also, in Barbados family study of open-angle glaucoma, they investigated the inheritance of primary open-angle glaucoma among families of black race, and also found family history to be a major risk factor for glaucoma confirmed by direct examination of the relative. But still, the family history alone cannot be accounted for observed prevalence of the disease, suggesting that a non-genetic factor plays a significant role in overall occurrence of glaucoma. What about diabetes? Several studies actually investigated the possible relationship between primary open-angle glaucoma and diabetes, and the prevalence of primary open-angle glaucoma was higher in diabetic individuals compared to non-diabetics, around 4.2 versus 2% respectively. One study that in Blue Mountain Eye study glaucoma prevalence, they found that glaucoma prevalence and ocular hypertension were more common in people with diabetes. Other prospective study of glaucoma management reported a greater likelihood of progression in patients with diabetic that was mentioned by Khani et al. In their study about the diabetes as a risk factor. Another study done in Baltimore Eye Survey, they found that association between glaucoma and diabetes was found to be very weak. And also, the unexpected finding from the ocular hypertension treatment study suggests that subject with self-reported diabetic actually had lower risk of progression to primary open-angle glaucoma, and they found self-reported diabetes to be a protective factor when they calculate the risk. One also important study, the Blue Mountain Eye study, reported a significant and constant association between diabetes diagnosed by history or elevated fasting plasma glucose level and glaucoma. As you can see from all this controversy between the study, some of them they have strong association, some they have weak, some of them they reported this as that diabetes is a protective factor. So the effect of diabetes on the development of primary open-angle glaucoma remain controversial. What about hypertension? In Blue Mountain Eye study, also participants with the glaucoma were more likely to have systemic hypertension than participants without glaucoma, 65.7% versus 45% respectively. In fact, the positive association between elevated pressure and primary open-angle glaucoma was reported. Larger population-based study like Framingham Eye study and Baltimore Eye survey failed to confirm this association. Smith et al. They found in their study that systolic and diastolic blood pressure also showed a modest positive association with primary open-angle glaucoma. When they adjust for age, that individual with systolic blood pressure more than 30 had higher prevalence of primary open-angle glaucoma. Also, lower perfusion pressure they found in this study was strongly associated with increased prevalence, with a 6-fold excess for those in the lowest category of perfusion pressure. So this is the main risk factors that have been mentioned in the literature. They found also other risk factors, like myopia, exfoliation, migraine, and caliber of the retinal vasculature have been reported as a risk factor. study done by Perkins, he found that increased frequency of myopia among patients with ocular hypertension or primary open-angle glaucoma. So in his study, he found that 60% of the eyes progressing from ocular hypertension to glaucoma were myopic. And in Beijing eye study, subjects with myopic refractive error exceeding -6 diopter had a significantly higher glaucoma frequency than a group with low myopia or emmetropic. Migraine has been reported as a risk factor for glaucoma progression, and in some study, and in the Blue Mountain Eye study, after adjusting for age, they found family history. When they adjust the age, family history, and diabetic and hypertension and capital disc ratio, they found also the narrow central retinal artery was associated with a higher risk of incidence of primary open-angle glaucoma. So this is mainly about the primary open-angle glaucoma, and it is a risk factor and it is a progression. Now we'll move to what we'll highlight about the ocular hypertension. As we know, the ocular hypertension is, as we said, the IOP is one of the major risk factors, and actually is the only modifiable one in the open-angle glaucoma. And patients with ocular hypertension usually at, as we said, greater risk for developing the disease. So the predictive factors for conversion from ocular hypertension to primary open-angle glaucoma can be used to guide the clinicians in determining how aggressively to manage the patient with ocular hypertension while individualizing the care. So the definition is ocular hypertension is high intraocular pressure without any evidence of structural or functional damage by standard clinical tests. They have to have open angle. There is no evidence of ocular or systemic cause of this high IOP. It is generally accepted that 1 to 2% of ocular hypertension patients develop primary open-angle glaucoma annually. As you know, sometimes open-angle glaucoma can be diagnosed in patients even without elevated IOP, either due to diurnal variation or other factors. It is also important to understand why some people with ocular hypertension develop primary open-angle glaucoma and the others do not. So different clinical response to IOP are likely due to the intrinsic factor that vary from patient to patient. This includes neuroprotective factors, microstructural anatomy of the optic disc, immune response, or even difference in optic nerve blood flow. So we'll highlight the major or larger randomized clinical trials that have been studied the ocular hypertension patients. We'll start with ocular hypertension treatment study, and this was done in 2002, and their objective to determine the safety and the efficacy of topical ocular hypertensive medication in delaying or preventing the onset of primary open-angle glaucoma. So they have total of 1,636 participants without any evidence of glaucoma damage, age 42 to 80. IOP, it has to be between 24 and 32 in one eye and between 22 and 32 in the other eye. So patients need to have high IOP in both eyes to be enrolled in the study. And they randomize patients to either observation or treatment with commercially available topical ocular hypertensive medication, and they will choose the medication based on the systemic situation of the patient to avoid the common side effects. And the goal in the medication group was to reduce the IOP by 20% or more and to reach IOP of 24 millimeter per mercury or less. So they have to have both goals to be described as goals. So during the course of the study, the main reduction in IOP in the medication group was 22.5%, and the IOP declined by 4% in the observational group. at 60 months, the cumulative probability of developing primary open-angle glaucoma was 4.4 in medication group and 9.5 in the observational group, and this was significant. So they conclude with the study that topical ocular hypotensive medication was effective in delaying or preventing the onset of primary open-angle glaucoma in individuals with elevated IUB. But in fact, if you have this idea about decreasing pressure will lead to decrease the chance of patients getting primary open-angle glaucoma, you need to identify which risk factor that in patients who developed primary open-angle glaucoma, so you can adjust your or tailor your medication based on management based on the risk factor that patients have. So the same group and the investigator of the ocular hypertension treatment study, they came out with another study to describe the baseline demographic and clinical factors that predict which participants in the ocular hypertension treatment study developed primary open-angle glaucoma. So the baseline demographic and clinical data were collected before the randomization, except for the corneal thickness measurement, which was performed during the follow-up. So the proportional hazard model were used to identify that predict which participants in the ocular hypertension treatment study developed the primary open-angle glaucoma, and they conclude their results with this predictive factors. They found 5 predictive factors that were good predictors for onset of primary open-angle glaucoma in the ocular hypertension treatment study, and they found the baseline age, vertical curve disc ratio, pattern standard deviation, and intraocular pressure, and at the end, the powerful predictor, which is the central corneal thickness. And they found that eyes with corneal thickness less 555 or less, they have 3-fold greater risk of progression to glaucoma at 5 years when they compared with participants who had corneal thickness of more than 588. If you can see here on the right side, there is 3 risk factors, which is the race, African American, male gender, and heart disease. Actually, those 3 risk factors, they found this significant in univariate analysis only, but when they compare when combined all the risk factors, they found it not significant. So they based their predictive on only these 5 factors. Those some factors, baseline factors that were not associated with the risk factor, with the risk of developing open-angle glaucoma in both univariate and multivariate models in the study, which is family history of glaucoma, mean deviation, corrected pattern standard deviation, myopia, migraine, and cerebrovascular accident, high blood pressure or low blood pressure, use of oral adrenergic antagonist, or oral calcium channel blocker. If we can see here also, this is the univariate analysis, and this is the multivariate. If you can see here, the African American origin was a 1.5 in univariate analysis, but when it came to the multivariate, they found that it is 0.9, and that was not significant. This is also the figure that showed the importance and the powerful of central corneal thickness as a baseline risk factor when they combine it with intraocular pressure. So if you can see here in this square, patients having normal intraocular pressure, but still the corneal thickness less than 555 is giving the patient chance to be compared to glaucoma more than other risk factors. Once the IUB also increased, the risk is increased, but still alone corneal thickness can be a risk factor. Also, they combined this with the cup disc ratio, the vertical cup disc ratio. If you find the first square here, the cup disc ratio is less than 0.3, which is normal, and still the corneal thickness less than 555 is the risk factor alone, and it is increased once the cup disc ratio increases. So the second large randomized clinical trial is the European Glaucoma Prevention Study Group. They evaluate the efficacy of reduction of intraocular pressure IOP by dorzolamide alone in preventing or delaying the primary open-angle glaucoma in patients affected by ocular hypertension. The participants' age usually from 30 to 80. Inclusion criteria was to have 22 to 29 millimeter mercury as IOP only in one eye, two normal reliable visual field, normal optic disc determined by reading centers, and the intervention was randomized to treatment with dorzolamide or placebo. The main outcome measures the efficacy and endpoint were visual field, optic disc change, or both. And usually the visual field is confirmed by two tests, and the optic disc also change was confirmed by two examiners. And they conclude in this study that dorzolamide reduced the IOP by 15 to 22 through the 5 years of the trial. However, the study failed to detect a statistically significant difference between medical therapy and placebo in reducing the incidence of primary open-angle glaucoma among a large population of ocular hypertension patients at moderate risk for developing primary open-angle glaucoma. Because also placebo significantly and constantly lowered the intraocular pressure. So they came out with their conclusion of the predictive factors. They found 5 factors, which is baseline age, vertical and horizontal cup disc ratio, bottom standard deviation, lower corneal, central corneal thickness, and baseline cup disc ratio asymmetry more than 0.2 between the eyes. And if you can see here, the other factors on the right, pseudoexfoliation, cardiovascular disease, and greater IOP, it was significantly affecting the patient as a risk factor only in univariate analysis. So when you combine both trials, you will find that that the patient is you will find patients with older age, thinner central corneal measurement, increased cup disc ratio, and greater bottom standard deviation. They have more risk to develop primary open-angle glaucoma in both studies. High IOP in ocular hypertension treatment study alone, baseline cup disc ratio asymmetry in early in European glaucoma prevention study was a risk factor, while the other one on the right side only they found the univariate analysis to be a risk factor. Now actually, if you can see, there is a lot of study that they mentioned that African American, they are more susceptible to primary open-angle glaucoma. And what they found in the ocular hypertension treatment study, the patients with African American, they have thinner corneas and larger cup to disc ratio, and this was the cause of their conversion to open-angle glaucoma, not the race itself. Okay, so with this, all this information, we need to have a specific risk calculation. So if you have all this information, so if you have patients with high IOP, patients with abnormal beta standard deviation, how I can classify this patient either to start medication or not, and what is the risk? So this you will start to convince the patient about his problem. So risk calculators or predictive models are essential parts of the healthcare, and identification of this risk factor for developing or progression of the disease is fundamental component in the construction of this model. Actually, the concept of the risk factors become widespread in medicine ever since the landmark Framingham Heart study first reported in early 1960 that cigarette smoking, elevated blood cholesterol, and high blood pressure were predictors of the likelihood of dying from heart disease. So risk assessment and prevention has contributed significantly to reduce the mortality from cardiovascular disease, and its successful implementation in this scenario has stimulated its application to several other areas and specialties. So what happened in glaucoma, the Mansberger and Medros et al. They developed a point system for baseline predictive factors to help estimate the 5 years risk of progression to glaucoma. So they use this point system based on the data from both hypertension treatment study and European glaucoma prevention study. So what is the benefit to the patient if you have the risk calculator? So they may provide benefit to the patient regarding the compliance. Also, the risk calculator provides clinician and individualized estimate of the susceptibility to developing glaucoma in 5 years for patients. So that risk calculator encourage treatment to be patient-centered rather than population-based. Also, the 5 years cumulative probability of developing glaucoma was 9.5 in untreated group and 4.4 in the treated group in the ocular hypertension treatment study. And this results in relative risk reduction of 54% and absolute risk reduction of 5.1. And this is a good number. In other words, this patients are more likely to adhere to therapy if you give them the risk, and if they have also definitive expectation of the risk rather than something vague in the clinic, just you tell them that you have higher or lower risk. So I guess this risk calculation will strengthen the physician-patient relationship and enhance the patient compliance. Also, sometimes the care provider or the ophthalmologist should avoid treating every patient with ocular hypertension. A risk calculator sometimes can help select those patients who will most benefit from the treatment because of their high risk of developing glaucoma. Sometimes you will have, when you do the score, you will have patients like borderline risk. So this is the provider experience and the patient's input can provide a guidance regarding whether to start treatment or no. So what happened? The Mansberger et al. They developed the risk calculator by a point system, and they include the risk factors that have been mentioned in the ocular hypertension treatment study, which is age, IUP, central corneal thickness, pattern standard deviation, and vertical capital disc ratio. And they added diabetes as a protective factor as what happened in the ocular hypertension treatment study. It was also subsequently validated on independent population of around 126 patients with ocular hypertension who were followed as part of a prospective longitudinal study that conducted in the University of California in San Diego. And all variables had similar performance except for diabetes, which was not significantly associated with the risk of developing glaucoma in this study, but was a protective factor on ocular hypertension treatment study. So in 2007, the investigator from both study, ocular hypertension treatment study and European glaucoma prevention study, they published a result of development and validation of the risk calculator for glaucoma based on the analysis of combined study data set. And the result was the same as the one published in 2005, except for diabetes. Sure, and they have the risk calculator contains the 5 variables that we mentioned, which is age, IUP, corneal thickness, Batten Sand deviation, and vertical cup disc ratio. Also, several other factors were not found to be significant related to the risk of conversion glaucoma in a combined both data set, which is diabetes, history of heart disease, and race, among others. So what they have, this is the point system that they came out with. If you can see here, the age every decade will have 1 point, and IOP every 2 millimeter per mercury will have 1 point, and corneal thickness every 25 micron will have a point. Cup disc ratio every 0.1 increase in cup disc ratio will have 1 point, and the Batten Sand deviation every 0.2 to the increase in positive side will give you 1 point. Then you have the sum point at the end, okay, and you will see the patient estimated 5 risk by percentage, if you can see it at the lowest area. So if you have this point system, one of you here will say, okay, but I have the risk for 10 years, but how, at what time I should start, or at what percentage I should start the medication? Patient, some of physician will start at, if the patient have 10%, some of them when the patient have 20%, some of them they have 15%. And this question was addressed by Medros et al, and they found he put the 15% as a threshold value. And this, once you choose the patient with 15%, this implies that leaving untreated patient who later developed glaucoma is approximately 5.5 times worse than treating patient who does not develop the disease. So they put the 15% as a threshold. This is from the Medros also study. He categorized the risk factor, and he put the percentage of glaucoma risk increase per, if you can see, per every decade, patients will have 22%. Every 1 millimeter increase in the IOP, they have 10%. Every 40 micron decrease in the corneal thickness, patients will have 71%. And 0.1 cup disc ratio, they have 32%. And increase in Batten Sand deviation 0.2, they have 27%. So if you can see, the most important number was the central corneal thickness, as mentioned before in the ocular hypertension treatment study. So what you need to use this models or the risk calculated, you need the age, vertical cup disc ratio, IUP 3 measurements by Goldman, central corneal thickness 3 measurements, and Batten Sand deviation using either Humphrey full threshold 30-2 or 24-2, CETA standard 32 or 24-2, and also you can use Octopus 32-2. They have generate 2 methods to be used to estimate the 5 risk of developing primary open-angle glaucoma from their study. The first one is the continuous method based on the actual data of the patient, and the simplified point that I showed you before, which is will give you a range to put the patient in. So this is the continuous method for estimation. Just you will go to the website, you put the IUP 3 measurement, then you put central corneal thickness 3 measurement, vertical cup disc ratio once, and the Batten Sand deviation 2 measurements. Then you click estimate the risk, then you will have the percentage. This is the other point system also that I showed you before. It is contain a range So you will click once you have the age, like if you have 50, you will click on 1. So it will give you a range on. And if you do both methods, you will find the results a little bit similar, but that's not very identical. There is previous also model that one by Mansberger in 2005 before those models, and he included the diabetes. And if you click on yes and diabetes, this will give the patient -9 point, because they found the diabetes is a protective factor in OK hypertension treatment study. This is the website that contains all this model. Just you can go in and put the data, and then you will find the patient percentage in front of you. Okay, so in summary, the prediction method present here are derived from two study, which is OK hypertension treatment study and a European glaucoma prevention study. So there is no guarantee that the predicted risk factor is accurate for individual patients. And also the predictions are more likely to be accurate for patients who are similar to those participants studied in both study, and if the testing also protocol for your patients resemble those used in this study. So these prediction models were derived from study on the development of early primary open-angle glaucoma. It is not clear whether this model also predicts progression or of establishing disease or development of visual disability. It is important to emphasize that current risk calculator for glaucoma has been designed to estimate the risk development of earliest sign of the disease, which do not necessarily have an impact on the quality of the vision of the patient. Decision to treat patients or start patients on medication who is having OK hypertension is not an easy, and we need to take in consideration patient life expectancy, patient compliance, patient education, side effects of the medication, besides the risk factor that we have mentioned. Other new risk factor might be studied in the upcoming future, like diet, environment, and genetics, and their effect on the patient prognosis. So predicting the development of glaucoma from OK hypertension is cornerstone to deciding on whether or not to treat. A risk calculator may be an innovative approach to simplify the management of OK hypertension and glaucoma patients and provide evidence-based treatment. All this, the predicting risk factors, they provide benefits to the patient, clinician, and all the society as a whole. However, eye care provider should recognize that risk assessment is still evolving and requires refinement. Therefore, eye care providers should consider the results of the risk calculator as supplemental information when they deciding whether to treat or not. Thank you all for listening. I hope that we summarize some point for the audience.
Thank you, Rayan. Excellent presentation. Thank you for giving us this update. I think that every day of our basic clinic, we're doing this, measuring risk and benefits. If anyone has a question, please get the chance to ask Dr. Rayan. Right now is our great expert in risk and benefits. And I only have one question, Rayan. How do you think these OHTS and early manifest glaucoma trial can be applied to our patients in Saudi Arabia?
Okay, I guess Dr. Conrad, as I said before, we need to take in consideration multiple factors. First of all, you need to see the patient risk factor that patient is having. Then you will see the patient, is he patient education, does he know about the disease? And then you give him the fact that if you have been treated with this percentage, you will have this result. But in general, I guess it is useful and supplemental to use this risk calculator, and you make sure, or you try to make sure, at least the patient examination, like IUP, corneal thickness, and the other demographic data of the patient himself, that at least it look like the one used in those studies. As you said, it is, as I said before, it is very difficult to treat those patients. And I guess sometimes if you have a patient with a lower risk, like if you have patients, the risk came 10%, you need to take in consideration, is this patient going to follow up with you frequently? So this will affect your management. Sometimes you have patients with 20% risk, and the patient will follow up with you regularly every 3-4 months. Then you will see if there is any progression. But some patients, they will have lower risk, like 10%. And we all see some patients, they are not following up regularly, and patients might benefit from starting the treatment immediately.
Yes, I think that you had there a great point. My impression here is that a lot of the patients do not realize how serious is the condition that we are dealing with, how important is the treatment they are gonna go into it. I was struck the first year that I was here, when I was given an appointment for a patient recently had the surgery, and I said, well, I would like to see you in 1 week or 2 weeks, and the patient answered, no, it's not good for me, I have to come in 1 month. It was like kind of a strike in that situation. So I think that you had a great point there. We have to adjust all of these studies that come from outside with a totally different kind of patients and apply into our daily clinical practice and our reality that are our patients here. Thank you, Rayan. Very good presentation.